the reason why we're doing these series is to provide education and empowerment. There's a lot of facts presented, and the reason why is because a lot of the discussion that we have with our doctors is not always what we expect, because and we mentioned a lot of this last week, but at the end of the day, there's not a whole lot of updated training on menopause. And unless a doctor is really looking at the updated research, they may not know. And there's also the old recommendations of just kind of using birth control or IUD as the solution, which is not, for some people, it may be beneficial, but it's really helping you to understand what information you need to have the proper risk benefit analysis with your doctor to determine the right thing for you. Based on the research and the studies that I've seen over the last several years, it is very clear, and not only the research, but also what people report, the majority of people, but that's usually represented in the research as well. The relief of symptoms and the protective benefits of HRT are quite powerful. So that's why I am super passionate to be able to share this with you, so you have the information that you need. And it's I'm so happy to have Dr. Karen with me on this journey, because so many women are able to feel better because of that, and to have a longer health span, which is the quality of your years. So without further ado, we start again. If you didn't see last week's session, do watch the replay, because we are discussing different topics this time. There may be few overlaps, but it is really helpful. And I've gotten some good feedback about the information that was conveyed last week, and that it was helpful. So do have a watch. You can put it on 2 times the speed if you're short of time, because it is about an hour long. So today we are talking about how do you know if you're a good candidate for bioidentical support, and the pros and cons. Actually, next week, we are going to cover more in detail on all the lifestyle things you can do outside of hormones to support your hormonal health and just health and longevity in general. So that is next week, so stay tuned for that. But today, we're just talking about bioidentical hormones and the pros and cons. All right. So are you a good candidate for bioidentical hormone support? Well, the ways to know that is we look at benefits versus risk. That's how doctors look at it. And I just want to, let me just do a double check. Karen, you're with us, right?
Hi.
Yes.
Yeah.
Yeah, okay,
Sorry.
good. All right. And she had a Zoom update. So symptoms of deficiency, that's one of the biggest things. It starts in perimenopause through postmenopause. And I'll just scroll one slide. Symptoms of deficiency are these. Low progesterone, you can see sleep issues, anxiety, mood swings, shorter cycles, spotting, there's more than headaches and things like that. Estrogen, hot flashes, racing mind at night. Often women will say that they wake up at night and it's as if they're quite alert and they're hot, maybe sweating. That is usually indicative of the estrogen drop, and that signals to the hypothalamus in the brain to change the temperature. And then there's a little bit of confusion with the thermostat, and that's why we get hot flashes or we wake up sweating. Weight gain, belly fat increase, bloating, joint pain, higher cholesterol, fatigue, headaches, recurrent UTIs, urinary incontinence, mental fogginess, loss of glow, lower libido, vaginal dryness, pain during intercourse, even hair loss. Some, I haven't mentioned everything here, some report itchy ears, frozen shoulder. These are often indicative of an estrogen drop or an estrogen deficiency, because sometimes once estrogen has fully declined, not all of these symptoms take place, but a lot of them, a lot of them do. And then, as mentioned, in the perimenopause phase, you'll get those spikes. So you'll try, the body is trying to signal to the brain is trying to signal to the body to produce more estrogen. So it is bumping it up before it has the full decline, and you'll get symptoms of either estrogen dominance or spikes, heavy periods, PMS symptoms, breast and nipple tenderness, cramps, allergy flares, also heavy periods, heavy bleeding or longer periods. Those types of things will come. And then you'll have these symptoms here of testosterone, low testosterone. You'll have the spikes as well. Not everyone has those. For DHEA, there's no obvious symptoms. And the reason why I reiterate that is just because a lot of these symptoms overlap with other health things that could be going on in our our life cycle and our body. So for example, you could have anxiety outside of having an estrogen decline or a progesterone decline. So that's why it's important to just really understand. It doesn't mean you need to have all of them to know that it's low progesterone, but it's something to keep in mind, especially if you notice those symptoms increasing around age 35 or in your 40s. This is a good sign that it can be hormones as well. Okay, so I'm going to go back to deficiency. If you have symptoms of deficiency, that's a number one reason why you may be a good candidate for hormonal support. Anyone who's postmenopausal, any woman who's postmenopausal, it is a good candidate generally, as long as you're not, you don't have these contraindications. And the reason why is because it has protective benefits for bone loss, for cognitive health, for arterial function, so your arteries, your heart health, and your vaginal health, which I'll come to in a little bit. So it's generally helpful. So 80% of women will, it's 80 to 85% of women have symptoms of deficiency, especially going through menopause, but not every woman does. However, there's research to support that even if you don't have a symptom, it is still going to be beneficial and protective, especially bioidentical, because that has studies on, it's a less risky profile. Dr. Karen, would you want to go through the rest of these and add any more if you'd like, please?
I think the main point I just want to make is that exactly what you said, that a lot of the times people are having symptoms that are not necessarily specific to hormone deficiency. So it's quite a tricky thing, especially if a lady's younger. You know, if you're around 49 up to 51, that range, and you're getting symptoms, then a lot of the time it's much easier for us to say, oh, it's definitely menopause or perimenopausal symptoms. But if a lady's younger than that and experiencing some of these symptoms, it becomes a bit more tricky. With regards to the contraindications for people who we would be very cautious prescribing hormone therapy, I think we obviously look at the previous history of the person themselves. And so if there is a history of any kind of vascular complication, heart attacks, strokes, any kind of peripheral vascular disease, then we'd be very, very cautious. Women who've got high cholesterol genetically are also a bit tricky. And then thromboembolism. This is one that's like a big question for us as doctors. And I know there is some evidence that if you use topical like gels or patches for hormone therapy, then you can perhaps consider using that treatment for someone who's got a clot or had a clot before. But we've got to be really, really careful. So, you know, we've got to obviously play very safe when we're deciding whether somebody can or cannot take hormone therapy. And I think, you know, with anything in medicine, you've got to look at the potential benefits and you've got to look at the potential risks and weigh those up very carefully. So obviously we look at the person's risk profile, but we also look at the family history. And we ask questions around, is there any complication in your family that could genetically place you at risk for certain complications? And so it's always a very intense kind of discussion, and therapy is very sort of individualized. We have to make a choice that suits the person with what they're experiencing, and obviously try and minimize any potential risks.
Yeah, thank you. All right, so we've gone through those slides. What I would like to do now, again, benefits versus risk. The benefits, it's generally been stated, and this is also paraphrased from the North American Menopause Society, which is in Canada and the US, but benefits of HRT often outweigh the risk, especially for those within 10 years of menopause and with symptoms. And the reason why we say that is just because they have, with the studies that they've done, they've seen that those who have started early with hormone replacement therapy had more benefit and less risks. Like the profile is much lower. Those that started after 10 years had some riskier scenarios. And one of the reasons I did mention last week is blood clots, for example, and blood clots happen more with oral and synthetic estrogens. It's known to have a link with oral and synthetic, whereas it does not have a risk transdermally. However, if a woman has had a lack of estrogen because she's gone through menopause, she may have developed some plaque in her arteries, and that plaque is just kind of sticking there. Well, estrogen opens up the arteries and cleans out everything, and then sometimes that plaque can get dislodged and it eventually causes a blood clot. Whereas if the person had estrogen the entire time, they theorize that that's why that's not happening when someone starts when they're younger, is because they keep their arteries open. So that's really the main reason. And obviously the biggest amount of symptoms come at the transitional period of perimenopause through the early years of menopause. So they see that there is a large benefit compared to the risks. Recent evidence says that the risk of serious side effects from HRT are very low, especially topical, or known as transdermal. The outdated studies show the risk, which I mentioned in last week's call, and most of these have been rescinded. So we're going to talk about the bioidentical HRT advantages. And again, bioidentical. So I just got a comment from someone I know yesterday who went to her doctor in Europe, and the doctor said bioidentical is a scheme or something. And I thought that was quite interesting. Bioidentical is often a marketing term rather than a medical term, but what it actually means, and most doctors who are studied and up to date on their research will understand the difference. Bioidentical means body identical. It's exactly the same compound that your body makes. Whereas synthetic, it is not the exact same compound. So that synthetic estrogen that we were talking about in the WHI study last week was horse urine, which has some similar compounds as estradiol, but it is not estradiol, which is what the body makes. So bioidentical or body identical, your doctor may use different terms. Whether it's marketing or not, there are pharmaceutical companies that are producing these compounds that are exactly made in the body topically. So that's how you can get that. I just want to clarify this. Dr. Karin, do you have anything to add?
Yeah, what's tricky is that, with bioidentical hormone therapy, a lot of the treatments are compounded, which means that if I go and see a doctor and I'm describing my symptoms, especially with a functional medicine doctor, then they take blood tests and then they'll make a compound with bioidentical hormones, estrogen, progesterone, testosterone, etc., which then is specifically made for me. The difficulty with that is that you cannot do clinical trials on different hormone compounds and look at the safety data and test and see, because you're not testing the same thing and the same product over a period of time. So a lot of the gynecology bodies, associations around the world, they don't really recognize bioidentical hormone therapy as a legitimate treatment, or at least they're still hesitant to recognize it as a legitimate treatment in that compounded form, because we cannot do the same kind of clinical trials as we would on a standard pharmaceutical product. So the difficulty is that we do have some bioidentical standard pharmaceutical products. There are tablets, there are patches, there are gels and creams, but the variety of those is not as wide as what we have in terms of the compounded stuff. So I think that's why a lot of doctors also are a little bit hesitant on acknowledging this treatment, and why it's not really mainstream yet, but it's coming.
Yeah, I think it will be more mainstream because more and more people are talking about it. There are more studies and more people are benefiting, and a lot of women are just tired of suffering. So yes, the compounded is very interesting also because in the US, compounded pharmacies weren't extremely regulated, and they have put more emphasis on regulation in the past few years. So there is, in fact, they have so many regulations now that sometimes it can put them out of business. But even so, so compounded does have people have reported more benefit because they're getting the dosage that's right for them. But again, this is testimony. This is anecdotal. We don't have clinical trials because you can't regulate all of the different variables that go into compounded. And so some doctors may be confusing the bioidentical with compounded. I was actually surprised, Dr. Karin, that this person mentioned that their doctor had said this coming from Europe, because in Europe, they've been using the topical bioidentical for quite some time.
I think it depends on where the doctor is, what training they've had. You know, you never know what the background is of the person who you're going to go and see. So a lot of us have got opinions on certain things, and a lot of the time, if we don't know something, we'd rather say, well, you know, that's nonsense, rather than saying, I'm sorry, I don't know. Please let me look at it, let me research it, or let me rather suggest that you go and see a colleague of mine who has got that understanding and knowledge. So I think, you know, it's quite a tricky thing.
Right. And I also think there's a certain amount of information that they have on board that they think works or has worked in the past, and they're sticking to it. And so not looking at what's up to date. And it's not only about what's the trend, because you don't want to just follow a trend, but you also want to understand, why is there a trend? Is there something different behind a trend? Because there is a trend now. It is up and coming. More people are talking to their doctors. However, with that said, the menopause experts that I follow in the US are generally advising the people that are coming to them. Obviously, they're patients. They're advising in a balanced approach. But there are many people who are followers, let's say on social media, and who will say, my doctor has completely dismissed me, completely dismissed all of this, and they're getting a lot of that. The expert gynecologist, OBGYN doctor, whoever it is in hormones, will just basically advise, go find a new doctor, which can be incredibly frustrating to have to change doctors. But at the end of the day, there needs to be alignment, and there needs to be that information and education that every woman really should have. And unfortunately, not every doctor has the updated information. Okay.
Challenge.
Yes. So HRT advantages. I mentioned the symptoms earlier. Reduction in heart disease risks. Cognitive benefits, I'll go through these in a little bit more detail. Reduction in the risk of Alzheimer's, reduction in the risk of osteoporosis, some cancers, increase in life expectancy. You're maintaining your muscle strength, or at least reducing the loss of it, which is called sarcopenia, reducing insulin resistance, so protection for diabetes, and quality of life improvement. I am going into detail because it is important for you to be aware of what this entails so that you feel empowered once again. So symptom alleviation, we talked about a lot of these: anxiety, sleep issues, mood issues, joint pain. HRT is FDA approved in the US and the most effective treatment for vasomotor symptoms, which are hot flashes and night sweats. Frequent vasomotor symptoms on average are VMS, that's why I put it there, on an average of 7.5 years, but for many could be 10 years. And there are some outliers that report over 20 years of these symptoms. It is the most effective treatment. There's so many little nice supplements, and there's even a new pharmaceutical drug out there that has a lot of controversy around it just to prevent hot flashes, but they're not actually doing all the other things that estrogen can help with. But they can be beneficial if someone should not be taking estrogen. So it's good to know that. But in general, it is the most effective treatment. HRT is FDA approved and the most effective treatment for genitourinary symptoms. Now, I will say that semicolon shouldn't be there, but I will say that I'm not aware of all of these yet, right? And a lot of us don't know what could be coming. But when you see women who are older, they have a lot of these symptoms that can actually be largely prevented or reduced by having adequate levels of estrogen. Vaginal dryness, burning, irritation. Sexual symptoms: lack of lubrication, discomfort, pain, impaired function sexually. Urinary symptoms: your urgency, recurring UTIs, dysuria, which is also known as pain, burning, itching, stinging of the urethra during your urination, and pelvic floor disorders, and basically anything to prevent a woman having to wear diapers or depends. This is huge, and we don't think about this because this is far out for many of us, but it is still something to be aware of. This next statement, the more severe your symptoms, the higher the likelihood to have dementia, cardiovascular disease, and bone loss. This is coming from the research that where they see the higher the symptoms, the more severe basically the symptoms of deficiency are. So symptoms, again, in general, as not even only about perimenopause and postmenopause, your body speaks to you, and the more you listen to it and the more you understand what it's trying to tell you, it is so much, there's so much wisdom in that. And so don't dismiss it or think just because that's what all women go through, I'll just have to suck it up. So just be aware, because it is a sign your body is telling you. So just on reduction in heart disease risk, observational data and meta-analysis, basically a study of many studies, show reduced risk in coronary heart disease in women who initiated the hormone therapy younger than 60 years or within 10 years of menopause onset, which I mentioned earlier. Perimenopausal women, so there's more studies that need to be done for starting in perimenopause, but they see the earlier you start on the onset of menopause, the higher the benefit. And then perimenopausal women get that symptom relief if basically if they have those symptoms, they start taking a little bit, let's say estrogen, progesterone cream, and their symptoms reduce. That's a good sign that they have been deficient. So perimenopausal women have a decreased risk of coronary heart disease. This was based on a study, approximately 41% decrease. This is huge, especially genetically for me. I have both sides of my family, and also shown in my genetic test, I have very high genetic vulnerability for cardiovascular disease, for blood pressure, for high cholesterol, all of these things. And there is a decreased risk if I start taking it early. This is huge. I actually noticed I was starting to have palpitations. I was also going through a stressful period. But once I started taking a little bit of estrogen, I'm taking extremely low dose because I'm still in my early 40s. I don't need anything high at this point. And I noticed when I went a little bit higher, it was too much. So I found my dose. And I noticed my palpitations did dissipate, and my blood pressure has always been low, started to creep up, and then went back to a low to normal level after taking estrogen. And this was independent of the stressful period that I had. So that's testimony. But again, we're looking at the studies. There is a decreased risk, which is amazing for anyone who's genetically vulnerable. And then the Esther studies observed a 4-fold increased risk of blood clots in oral hormone therapy versus non-users. And then no increase in VTE is also basically blood clots. I forgot to change it to this layman's term. And transdermal, that's the topical hormone therapy users. So a huge difference there when you take it orally. And it was really oral estrogen in that sense. Okay, so cognitive benefits. Alzheimer's disease or dementia mortality was reduced in women using estrogen alone. Women who initiated hormone therapy early performed significantly better on cognitive tests than women who initiated late or not at all. There's studies on this critical window. It's actually, I think it's called critical period. There's a critical period to start estrogen for the benefit. So again, another reason why it's good to start early. But I just want to come back to this first point. Alzheimer's disease or dementia mortality was reduced in women using estrogen alone. What about the women who were using estrogen and progesterone? Well, I have to disclose this because it's really important, but they did find an increased risk when they first showed this, and that was the synthetic progestins. Then what happened is they were really trying to understand what is it, what is happening. Now, maybe it's because of the synthetic progesterone, because they haven't done a head-to-head with synthetic progesterone on dementia. But what is interesting is that what they've found is that there are people who started the study there's some people that had mild cognitive impairment. That means they were already starting to lose their brain power. They were still kept in the study. And that is the precursor to developing Alzheimer's. But when they removed the people with mild cognitive impairment, so a little bit of brain fog, a little bit of brain thinking, cognitive issues, memory, when they removed them from both arms of the study, there was no difference between the people who were taking hormones versus the people who weren't, because obviously those people were already on their way to developing Alzheimer's anyway. So there was no statistical difference, but it was clear here that if they were just using estrogen alone, it was reduced. And again, you can only use estrogen alone if you don't have a uterus. However, it has been shown that progesterone does have some cognitive benefits on mood, on anxiety, and on sleep. And the progesterone that's transdermal topical is less risky than the oral synthetic progesterone that was used in those old studies. So estrogen enhances learning and memory. Progesterone protects the growth and repair of the myelin sheath, which is part of these brain nerves that allow that connection between neurons and enhance memory. So this is really important. And those with a genetic Alzheimer's predisposition. So these people had a gene called the ApoE4, which means that they have a higher genetic vulnerability to getting Alzheimer's, which can largely be reduced with exercise by 50%. But still, if you have a predisposition, there is more vulnerability there. They had less difficulties with basic attention processes and speed of information processing using hormone replacement therapy that those that didn't use. So even if you're genetically prone, estrogen is beneficial.
So Lindsay,
Yeah.
If I understand correctly, the power is in the prevention.
Yeah.
Meaning that if you start before you've got any brain problems, then that's the point at which you can have a difference. But once you have got some established issues, it's not going to make a difference.
Right. And what they've seen in studies is that the earlier people start, the more benefit they're getting. I don't think they understood this before, so they haven't. I would say there needs to be more studies on this because I don't think there are enough. With that said, though, with the studies that have been done on women starting earlier, there are benefits, especially as soon as someone is getting symptoms at the onset of menopause. For perimenopause, there's that 41% decrease in coronary artery disease. There's been a couple of studies, but there needs to be more on the early perimenopause. But you see, as soon as they start the onset of menopause, definitely largely preventative, and it is helpful.
Very interesting.
Yeah. Yeah. So it's actually quite exciting too, because this is something that we were adverse to, we didn't know. And I do believe you will start to see, I mean, even the North American Menopause Society, who basically gives their recommendations based on all of the research, updated research. They're still against compounded, kind of, as you mentioned, because there's just not enough research. It's not substantiated enough. But they are on board with bioidentical hormones, topical hormones. They are on board with the earlier you start closer to the onset of menopause, the more preventative, the better the benefit, the lower the risks. So that's kind of where they stand. And that's based on the research. Okay. Let me move to reduction in the risk of osteoporosis. So it is FDA approved also, and the first line of treatment for prevention for osteoporosis, estrogen. So it's not the osteoporosis drugs, it is estrogen is the first line of treatment for prevention. And it's shown in double-blind randomized controlled trials to prevent bone loss. And it's also known for the prevention of postmenopausal osteoporosis. And so we're talking prevention, but this is also to help reduce fractures. So so it's not only, I mean, obviously it's to prevent fractures, but in general, it is not as well known once somebody has full-blown osteoporosis to help as much, but it will still reduce fractures if somebody does have a fall.
Well, this is one of the indications for us to prescribe hormone therapy, is that if a woman has got osteopenia or osteoporosis, obviously the last thing that you want is for somebody to have a fall and they break their hip or they break their back. And so hormone therapy is certainly one of the considerations that we have. When somebody's got that kind of bone disorder, it's not always the first thought, but that's the registration for hormone therapy, is osteopenia or osteoporosis as well.
Yeah. Yeah. There's so many benefits here. All right. So breast cancer, again, this one's tricky. We mentioned last week, I'll mention a little bit more. In estrogen only, there is a reduced risk of breast cancer. And you see here, I say, however, in synthetic estrogen combined with synthetic progesterone, there was a slight increased risk. That's 4 more out of 1,000 when hormones are taken for 5 years on a large scale study. However, with that, there was no significant difference in breast cancer mortality. And again, that was one dosage, synthetic, oral, in a largely unhealthy population. 70% of that population was obese. And they didn't even start at the protective age. So we've got so many things against us in that study. However, with all of that said, since then, they've looked at progesterone with lower breast cancer risk. When you look at natural progesterone, which is the bioidentical, compared with synthetic progestins in combination with estrogen. So what was communicated before, I'm just presenting it in a different way than last week, but it is largely not applicable, because if you're talking about synthetic, oral, all the things that were different here versus natural bioidentical progesterone, there is a lower cancer risk. And then also, even if you've got the BRCA gene, which is the gene that has a very high predisposition of breast cancer. It's not, once you have that gene, there's not a whole lot, lifestyle doesn't make as much of a difference as some of the other vulnerable genes that can give you cancer. This one, over of half who used estrogen had a decreased risk of breast cancer. And this has been replicated with similar results, similar studies, because this was one cancer center in Canada, 472, I think another university in Canada, around 450 to 500 people did also use BRCA, and they also saw very similar results. I mean, it needs to be replicated in other regions of the world, but it's interesting because this is not what was always communicated. However, with that said, you've got all these nuances of cancer. It's not just a one-off thing that I'm saying, okay, it doesn't matter if you have cancer or not. There are estrogen receptor positive cancers, not always recommended to take estrogen. In fact, they take medicine to block estrogen at those times because those tumors actually have receptors that receive estrogen that could promote the growth. So there are nuances to cancer, especially while someone has cancer, but they do see prevention of cancer if you're using these bioidentical hormones. I'm sure Dr. Karn, you may have more to add here.
Look, again, it's quite a tricky thing. And if you like, I'll tell you a quick story from a doctor's perspective. One of my colleagues, fantastic family medicine specialist, was working at the practice where I was working before. And he went away on holiday, and a locum came and saw one of his patients. And what happened was that the locum got a request for a prescription to renew her hormone therapy. So the locum saw the patient briefly, said, "How are you? What's going on?" "Oh, perfect. Here's your prescription for your hormone therapy." About less than a year later, my colleague got a disciplinary request to appear for a court case. And what had happened is that the woman had passed away from breast cancer in the meantime. And the court found that it was as a result of the hormone therapy. So the problem was that obviously it was a locum, it was a stand-in doctor who prescribed the hormone therapy for the lady. And there was no screening, there was no checking, there was no cross-check to see that she'd had her mammograms and all of her other tests done. And so the settlement from that case, because we all carry insurance in case something like this happens, the settlement in that case was in the region of $3 million US dollars. So when you hear things like that, and obviously the stress that my colleague had to go through in appearing for all these disciplinary hearings and going through that process, it was horrendous. So from a doctor's perspective, having previous evidence of saying, these things are associated with complications, and also looking at the legal system where, they also work in a specific mindset, you will always find that people will err on the side of caution, which is better. But I think the point of my saying this is that we have to view these treatments in the light of the individual person, what benefit they're going to get, but also ensuring safety at the same time and making sure that we are up to date with all of our checks and keeping things in line. And having the full knowledge of family history, risk profile, previous history, and making sure that it's the correct and the safest thing to do.
Well said. And $3 million is a lot, but it's still probably not enough for that family member to replace that person's life. With that said, though, I will say in the menopause method training that I have undergone, when I have pushed back also on the, the frequent checking with mammograms and things like that, what the response that team has given is more about, you still need to, so he won't accept anyone in his practice who will not do a mammogram, because he's been practicing for over 30, 40 years. And he has said that independent if they're taking estrogen or not, he still has that requirement because he sees that there's no risk, but there needs to be proper screening, and he just won't accept, he won't accept a patient if they won't do it. So again, that's where there's flexibility in certain areas, and in other areas with each doctor, each one has their own boundaries. And that's why it's important to find a doctor that aligns with you and that you think is reasonably explaining and assessing your risk benefit profile and understanding your family history and all of that. So yeah, thank you for sharing that. Uterine cancer, there is a reduction in the risk of uterine cancer as well. There are more cancers, but I didn't put them here. Reduction in other risks, increase in life expectancy, all-cause mortality was significantly reduced in the pooled trial versus the placebo. So people do live longer. They have less mortality from cancer, less mortality from other things. Even if they have those events, they are living longer if they have taken hormone therapy. Maintain muscle strength. So sarcopenia is the loss of muscle, and a lot of people do lose muscle. Estrogen and hormone therapy does help with this. Reduce insulin resistance, reduce diabetes. This is huge. The estrogen loss does create more insulin resistance, and a lot of women will see increased belly fat and see changes starting to happen around that time. When they do take estrogen, they don't have as much insulin resistance or diabetes. I just want to caveat that belly fat, because a lot of people say, will the hormones help with my belly fat? And Dr. Karen, you can also comment. I think it's mixed results. I think some people really notice a difference and others don't. So there's so many other variables involved with belly fat.
It's the truth. And I think it's quite tricky because a lot of ladies will come with the expectation that the hormone therapy will be this magical cure for that specific problem. And a lot of the times we are a little bit disappointed, because I think there are definitely other factors that perhaps also interact on a deeper level. So it's not always the magic that we want it to be, sadly.
Yeah, it is. I do believe it's pretty magical, but yeah, it's not that magical in that instance. Depression, mood, and perimenopausal women, huge reduction there. So a lot of people equate this time with being a busy time or empty nesting, or maybe marital problems have increased. Women are getting stronger and not putting up with things. There's so many things that they associate the moods and depression and even anxiety with. With that said, there is definitely, even if a woman has all the other variables the same, she starts taking a little bit of hormones, that mood lifts, depression decreases, reduces, or is eliminated. There is a difference, and they have controlled for that in studies. So there's some benefit there. But again, this is only if it's hormonally related. If all those other things are so strong, it's not going to alleviate those things, obviously, and that's where you've got to get to the root cause of those things. Quality of life, simply because of all the symptoms are removed and you're protecting your health. Skin, I thought this was interesting. So estrogen therapy increases epidermal and dermal thickness, increased collagen, elastin content, improves skin moisture with fewer wrinkles. Dr. Karen, do you know if in Mauritius they have any skin cream with estrogen? Because in Europe they were doing that.
No, I've got one patient who, she's quite an older lady, like in her 70s, but she's got beautiful skin, like not a blemish, very, very few wrinkles, magnificent. And she swears by actually applying the vaginal cream, not in a big amount, but on her face. So I know of one person who does it, but like in South Africa, where I was working before, we didn't have any estrogen specific skin creams for that benefit. But I can tell you that if I look like her when I'm 70, I'll be very delighted.
Wonderful. And so the vaginal cream in is that also available in Mauritius?
Currently, it's in stock, so you can
Okay.
get, yeah, Premarin cream.
Oh, it's Premarin. So that's a
Mm.
synthetic. So it's not topical. Okay. Sorry, it's not bioidentical. So just good to know. Okay. And then I know in the US, a lot of women are actually using estriol, which is another type of estrogen on their face. But it is actually indicated for the face. But yeah, I would be a bit hesitant about using like that cream based on, even though it's not oral, it's still synthetic. So at least for
Yeah,
me.
I don't know about the absorption profile. If you use it vaginally, we know that it doesn't absorb in significant amounts, like you can't detect it in the bloodstream, which is why that is safe for us to use in ladies who've got a history of breast cancer, or at least it's not a contraindication. But I don't know about applying it on the skin.
Yeah. Okay. Well, it's for those who want to take some risk. So we'll see. Maybe in Mauritius they'll have them later. You never know. For the face, not the vaginal cream. But at the end of the day, it makes sense. If you can apply it there, then your face should be able to handle it. Okay. And it also in smaller trials, hormone therapy appears to decrease dizziness or vertigo and improve postural balance. So these are smaller trials, I think less than 2,500 women. So that's why it's considered smaller, but it has some benefit there. Okay. Side effects. Dr. Karen, I'll let you go ahead and cover these.
I think the most common side effect that I've seen in my patients relates to breast tenderness. Like most ladies at the initiation stage will come and complain to me and say, listen, my boobs, something is happening here. And a lot of them are sore. Some ladies have a bit of an increase in the volume of their boobs and stuff. So in clinical practice, that's probably the most common one that we see. I don't see breakthrough bleeding that frequently, and headaches are also pretty infrequent. But a lot of the time, what happens is that the side effects get better as you continue treatment. Or what we do is we kind of adjust the dosage a little bit down so that we can manage those. Um, I don't really see much of the nausea, bloating, weight gain, and stuff, but definitely it is possible. But like I say, you can often manage that according to reducing dosages or even changing the constituents of the product that you're using.
Yeah, that makes sense. And in the training I received, what they typically had recommended is you start on a low dose of estrogen, progesterone, then you titrate up to get to the dose where you actually have symptoms of excess, and then they back down. So they actually find your optimal dose. And which is an interesting way to do it. And there's different ways to do it. But in general, that's what they typically do. And a lot of the symptoms are because you're actually at too high of a dose. And so once you back down, as you said, then you can find that optimal dose. And that dosage may change over time. And that's why it's another reason to get the annual checkup, is just to make sure that you are in the right dosage, especially even if you're going through a period of high stress. High stress burns through the hormones faster. You may need a higher dosage. You also may need different dosages depending on where you're at in the perimenopause, menopause stage. Okay, Dr. Karen, take it away, please.
So we do know that oral synthetic estrogen, so this is the non-bioidentical estrogen, has been associated with significant vascular complications, blood clots, strokes, heart attacks, etc. But we haven't seen the same risks associated with those formulations if you apply them through the skin. And we believe that that's because you're not taking the tablet orally, so it's not going through the liver, which is responsible for making clotting factors and stuff. And obviously, that is a major concern for us, and that's really why we've been a little bit scared up until now. The bioidentical hormones don't seem to have the same risks, but we often still prefer to use the topical treatments for that. And obviously, the different formulations have got different dosages, etc. I've seen a few patients who have had the complication of endometrial cancer as a result of excess estrogen. and this is something that I really want to drive home, is that estrogen stimulates the lining of the uterus. And so if you have too much estrogen, or that estrogen is not balanced with progesterone, this is a very, very serious risk. And it's regardless of whether it's a synthetic or a bioidentical hormone. So that is one where we are very scared. So a lot of ladies, if they've been on hormone therapy for a long time and they haven't had any bleeding, if they start bleeding, we start panicking, because if, like, vaginal bleeding is often a sign that the lining of the uterus has sort of overgrown a bit and it's starting to shed. So that's an important thing just to remember, is that once you're through the menopause, you should not bleed ever again. And if you do, you need to be investigated for that. Like I said, the breast pain, the sort of breast enlargement, that's very, very common. And so we also know that estrogen can stimulate breast tissue if it's estrogen sensitive. And that's why we have to monitor very frequently with examinations and ultrasounds, perhaps mammograms, that type of thing. I have not seen gallstones or gallbladder problems with hormone therapy. And I've never really made the connection. We know that those are complications that happen at a particular time of life anyway. So usually after a lady is 30 or 35, the risk of having gallstones and things is higher anyway. But I wasn't aware of this until you mentioned it.
Yeah. And I think it's just something, it's not a very large risk, but they do see the risk with this. And but obviously with transdermal hormones, but they haven't yet confirmed this in RCTs, randomized controlled trials. So they still need to, these are the risks that are known. It's not very high at all. Relative risk is, I need to look at the numbers, but it's pretty low. Okay. Dr. Karen.
So from my side, I think there are some important messages. The first one is that bioidentical hormone therapy is certainly a better option than synthetic hormone therapy. From a risk perspective, it is far, far, far safer. It is, however, a medical treatment in the same way as thyroid disease is treated with thyroid replacement, which is a bioidentical hormone. It's exactly the same as what the body makes. We monitor thyroid conditions all the time to make sure that the dosage is correct and to ensure that everything is going well. So the same really applies to bioidentical hormone therapy for perimenopause, is that it is a medical treatment, and one has to make sure that we are monitoring and ensuring that, number one, it's doing what it says on the box, that you are getting the benefits that you want, but also, number two, that you're not having any complications or being exposed to unnecessary risk. And it's very important that before you initiate hormone therapy, you've got to have a thorough workup. We've got to make sure that we are not potentially exposing you to any risks. So have to go and see the gynae. We've got to know what the lining of the uterus looks like at that point, so that we know that if we give estrogen, it's not going to cause any problems. We do have to do breast examinations and breast imaging before we start any hormone therapy. You've got to have a bone density scan. I do that as a standard practice, because then we understand the state of your bones and we know whether hormone therapy will be a benefit to you. And in that case, we've got more motivation to use it. And then we always have to assess the cardiovascular risk. So we often do cholesterol, we check inflammation markers, obviously a thorough examination of your cardiovascular system with blood pressure and pulses and all of that stuff, so that we know that it's not going to expose you to unnecessary risks. And naturally, we've got to make sure that your symptoms will be alleviated with the treatment by understanding that your symptoms are definitely caused by hormone changes and not by something else. So, that obviously involves a little bit of investigation too. please remember that you cannot use estrogen by itself unless you've had a hysterectomy. So if a woman does not have a uterus anymore, we can use estrogen alone. I often don't do that because I don't find that the results of treatment are as good as if we use progesterone and estrogen together, just from a perspective of symptoms. But a lot of gynecologists and GPs will prescribe estrogen by itself. And one has to be very, very careful because estrogen stimulates the lining of the uterus, and that can lead to cancer. So this is the big no-no. And then, like I said before, we've got to monitor throughout the therapy and make sure that everything is going well, you are happy, and that we are not having any complications or intolerable side effects.
Yes, thank you. So our conclusions, generally benefits of HRT often outweigh the risk, especially the earlier you start with menopause. Even perimenopause, there are benefits as well. Recent evidence says that the risk of serious side effects from HRT, especially bioidentical, are very low. Outdated studies show the risk, which have now been rescinded, and the treatment should be individualized using the best available evidence to maximize those benefits and minimize those risks with periodic reevaluation, annual evaluation. So, and all the things that Dr. Karen just mentioned. So does anyone have any questions? In fact, if you would like, you can unmute yourself or go ahead and type it in the chat. We'll just wait a little bit.
Lindsay, while we're waiting, I think I lost connection at one point where I was talking about, or where you were speaking about the urogenital vaginal issues that come with menopause. And I think it's quite an interesting thing that the prevention of those issues is far better than having to treat them later. So, if you see a lady who's got established vaginal atrophy, where the lining of the vagina and that area is very thin because of lack of estrogen for a long time, even if you treat, let's say, with oral estrogen and vaginal estrogens, you're actually not going to achieve the premenopausal state. So, I've seen ladies who've got vaginal prolapse, who suffer with bad urine infections all the time. Their pelvic floor is not fabulous, so they've got a bit of incontinence. And the power of hormone therapy at that point to reverse those symptoms is not very much. So from that perspective, I definitely think that prevention is far, far, far better than dealing with the consequences later,
Yeah, no, absolutely. I mean, especially women, as you even showed in that testimony last week, that lady you worked with who ended up, who was over 100 years old at one point, she's like, just don't take away my hormone therapy. I mean, women who take it, they know the benefits, especially if they've ever had to go off, they can see that drastic change start to happen. But then a lot of other things start to happen gradually over time, and it's not pretty at all. Doesn't feel good. And I mean, there's even stories of women who've had to get their vaginal labia surgically split again because it kind of
grows closed.
Yes, and that's scary actually. We don't know those things when you're thinking, when you're younger, you just don't know that those are possibilities and things that don't actually need to happen if you've got some support hormonally. Okay, well, thank you everyone for your time. If you do have any questions, please don't hesitate to send them via email, WhatsApp, message, whatever you prefer. And good luck for the discussions with your doctors. I know that most of the people that are on the call now, because of the timing, are in Mauritius, so it's going to be a lot easier because you have Dr. Karen. But for those that don't give up, but do expect that sometimes you may not find that person who's on board. If you can, I would suggest beforehand, in the US, it's a little bit difficult, but to find someone who's teaching the menopause method, sorry, not the menopause method, who is certified from the Menopause Society, which I mentioned in last week's call. You can just check. And then obviously you've got to check for insurance as well. And for those elsewhere, it's important just to research a bit on those who support bioidentical hormone therapy, because the doctors usually generally will have a website or will have something informing you that they do support that. And that's just going to be a much easier discussion to have. Sending you all many blessings. Dr. Karen, thanks once again for joining me on this call. Have a good day. Thank you.
You too.